that, I will invite the next speaker. Dr. Rohit Saxena is well known and at least does not need any introduction in India. But those who don't know him, it's a small introduction to Professor Saxena, who looks deceptively very young, but he's a professor, and he did his residency training as well as postgraduate training at All India Institute of Medical Sciences. He has recently finished his PhD. As you can see, more than 250 publications across pediatric ophthalmology, neuro-ophthalmology, community ophthalmology, and he has a very, very large range and in publication. And his areas of special interest is complex trismus, neuro-ophthalmology, and of course, the topic he's going to talk on and has done some pioneering work for myopia. He's going to talk us on myopia in 21st century. Dr. Rohit, please.
Thank you very much, Sumita, for a very kind introduction. And thank you, Dr. Surendran, for giving me the opportunity to be here. Of course, it is absolutely a fit thing that we are discussing myopia control in this century, particularly over the past 2 years. We have seen that the entire the recipe for progression of myopia has been is really there, and we probably will see the impact of these past 2 years over the next few years as our children start coming back to school and hospital, and we realize what the this bound down period has done to them. So I'll be talking about in this century, what are we looking at and how we should plan and work on our children. I do not have any financial disclosures. So the first question is, why do we want to intervene? Actually, the world kind of sat up and took notice after this Brian Holden paper actually came out in ophthalmology, where they predicted that almost 50% of the world's population is going to be myopic by 2050. In India, I would say that we were even more kind of unaware of this myopia problem. And gradually, we have recently started understanding that there is a major issue among our kids also. We have found an increasing tendency or increasing incidence of myopia in our children. And again, we used to think that rural children would not be affected. And unfortunately, we've seen a much higher increase in myopia prevalence in our rural population as compared to the urban area. Although, of course, urban population, the prevalences rates are higher, but the increase is more in rural population, probably reflecting the urbanization of our rural areas. So this is the importance of us discussing and knowing what and how to intervene. So when would you want to intervene? You need to have a risk factor identification based planning. When there is a significant myopic refractive error of at least about a diopter or so, the age, genetics, and visual environment considerations that are increasing the likelihood of the child to be progressor and maybe a rapid progressor. The factors of genetics, most importantly being the parental refractive error, and both parents increase the risk of myopia almost 3 times. And of course, the most important thing is to document myopic progression. It's very, very important when you're taking a decision, because some children may be having congenital myopia. We'll see in a wonderful talk in ROP how these children who are born preterm are probably myopic congenitally and may not be the ones who are progressing. So important to document progression. How to intervene? Assess the refractive error and its progression, communicate, talk to the parents and patients about the risk factors and the importance of monitoring myopia, discuss treatment option efficacies, risks, and additional correction benefits, realistic expectations, and a lot of these treatment options are off-label. So again, important to take informed consent, do baseline examination, and start treatment and schedule follow-up. What are the options available? There are optical, pharmacological, and environmental. Optical, we have spectacles. We have some interesting DIMS or defocus incorporated multiple segments, aspheric lensed spectacles, progressive ad spectacles, bifocals, contact lenses in the form of ortho-K, soft multifocal, pharmacological, which has been in discussion for a long time, and it's a very, very interesting form of intervention and environmental influences. I'll quickly run through the important ones. This DIMS or the defocus-induced multiple segments is a recently in the market available by Hoya, which is the MyoSmart lenses. So they have a clear central zone for distance correction. And these are small areas of segments which are high plus lenses. And the importance is in the mid periphery, they create a myopic defocus, which is important to prevent progression of myopia. We'll see that in the other spectacle forms, but this is very interesting because up till now, giving peripheral ad in the peripheral part of the spectacle would reduce the field, because the moment the patient looks on the side looking through a high plus part, his distance vision would drop. So this system allows the child to see clearly for distance, while at most of the time providing a myopic deep focus in the periphery. So this is how it actually works. You have a good correction in the center, but peripherally these spectacles, normal single vision spectacles, give a peripheral hyperopic defocus, which actually stimulates the progression of myopia. And the key to prevent myopic progression is to provide this myopic defocus, and that's how these peripheral ad lenses work. Bifocal lenses provide or work on the theory that actually there is an accommodative lag, which is actually contrary to what we would have thought for myopes. So uncorrected myope, we assume, would be looking normally for near, but because they are uncorrected, they're not using accommodation, their accommodative power is not so well developed, and when corrected for distance, they actually have an accommodative lag for near, which creates that hyperopic defocus for near, which is responsible for progressive myopia. And again, that's how bifocal lenses work. Bifocal prismatic ad lenses add the balance between accommodation and verging system, and 3 basin prisms in each eye have shown to significantly reduce myopic progression by as much as 55% as compared to single vision lenses. So this is the other option, but this effect is predominantly in those children who have shown to have accommodative lag and a reduction or inability to converge adequately while looking at near objects. So this is the most effective group for these kind of patients. Orthokeratology was not actually introduced for myopia correction, for myopia prevention of progression, but more for myopia correction. But over time, they have found that because of the reshaping of the anterior corneal surface, there is a prevention of progression of myopia. There is also associated prevention of axial length elongation, but it predominantly works by refractive correction by reshaping the cornea. And myopic progression has been shown to reduce by almost 45%. The downside is that there has been a lag, a rebound that has been noticed after stopping it. The other, of course, problems of using contact lenses overnight is risk of microbial keratitis, non-availability in most areas, and that's why it's not such a highly accepted intervention in India. Even lack of expertise in actually dispensing ortho-K. Soft multifocal contact lenses started with the use for presbyopic correction and were found to again show that they may prevent myopic progression, has been shown to decrease myopic progression by almost as 34%, and a lot of multifocal lenses are now available commercially. Pharmacological, there were a lot of things tried, but currently the most accepted is atropine, low-dose atropine. The pioneering work done by the Atom group from Singapore, where they started with 1% and then gradually reduced it and said that 0.1% is highly effective. And recently, of course, the LAMP group from Hong Kong has shown that 0.5% is the most effective concentration vis-a-vis the side effects. And a very recent publication on a network meta-analysis comparing 8 concentrations actually has reiterated the fact that 0.05% may be the best for as far as efficacy and side effects are concerned. So, of course, 0.01 is commercially available in India and in some countries, and we hope and look forward to more work on 0.05 and easier availability. The key thing I want to discuss or want to highlight is the lifestyle and environmental modifications, which can be done uniformly across everybody. Increase outdoor activity during daytime, and now, of course, we have the countries opening up, and it's very important for children to spend outdoor in bright light. And it has been shown that up to 120 minutes a day of outdoor activity significantly reduces the progression of myopia. Reduced near work and decreased screen time, a thing that is almost impossible to kind of impose on today's children. The other measures, of course, being frequent breaks, the 2020 rule by APSPOS AIO, the increase in the ambient indoor lighting, maximize natural lighting in rooms. So sit next to bright windows, appropriate posture, preferably sitting on a table, and that would also help to ensure appropriate reading distances. So these are all the solutions on the impact on their efficacy. And you can see outdoor activity has a significant role to play in preventing progression of myopia. You analyze the treatment in the terms of progression in axial length elongation, which is very important because that is the key intervention we want to make to prevent long-term side effects. And of course, the other ocular parameters, it's important to note and make sure that they are being affected by the myopia treatment you're doing. When would you stop or change? When progression is not sufficiently controlled compared to expected progression, poor tolerance of side effects, and compliance and safety issues. So where are we? Increased awareness about myopia for the next generation is the most important thing we are really duty bound to do. We know outdoor activity works, atropine drops work, peripheral add lenses work, and ortho K works. You need to select treatment based on risk benefits of treatment, patient lifestyle, economic status, and ease of compliance. Thank you very much for the opportunity.
Thank you, Rohit, for that wonderful talk.